Welcome to Sculpting the Soul, where we explore the art and science of transformative surgery. We have an exciting and insightful discussion in today's episode. We'll be diving into the complex and unique skill set that Dr. Kalus has to conduct a singular surgery for breast cancer removal and reconstruction. Join us as we explore addressing a fatal challenge while delivering on the mission to help people look their natural best. Let's get started. Dr. Kalus, thank you again for giving your time to all of the listeners and patients that are out there that are utilizing this information to make educated decisions. We appreciate your time.
Thank you, Alan. Pleasure to be here.
Excellent. Well, as we look at this, at this particular subject, you happen to have multiple testimonials that have come across from patients for this specific thing. And from what I've learned through connecting with many of your patients that have given testimonial for your services through this, that this is a rather unique and challenging thing to do within the plastic surgery field. Can you kind of allude or explain why this is such a unique thing and why it's not every plastic surgeon necessarily does this?
So, first off, the diagnosis of cancer is a scary diagnosis for everyone. And in breast cancer, it's a little bit different because it obviously affects the body image, it affects the sense of sensuality and femininity, and this can be very, very impactful for not only a woman but her partner. So breast cancer is a diagnosis that is well known to our listeners, and the advances that have been made in the last 20 years have been dramatic. And the mainstay of breast reconstruction the world over is implant-based. Silicone gel implants are what is most commonly used. But the historical mechanism or technique which was used was almost always a two-stage approach, where at the time of the mastectomy, performed by the breast surgeon, the oncologic breast surgeon, a tag team approach with the plastic surgeon would follow with placement of a tissue expander, which is essentially a medical balloon that is put in uninflated at the time. Everything gets closed up, but basically there's the absence of the breast after the mastectomy with a flat skin envelope. And over time in the office, a little magnet device is used to find a port to inject safely a little bit of salt water, saline, to slowly inflate this balloon tissue expander until the desired volume is reached. And this can take a few weeks, it can take up to a couple of months, sometimes a little bit longer. That is still the most common approach used the world over. But about 20 years ago, a technique was developed that I have embraced wholeheartedly, and this is now constituting 95% of my breast reconstruction practice, perhaps even closer to 98%. And that is where we can safely proceed directly to the final implant. And the abbreviation for that is called DTI, direct to implant. And we're skipping the tissue expander. And so what that allows us to do is provide the patient with a single stage breast removal, if that's what's indicated, for the treatment of her cancer, followed by an immediate reconstruction under the same anesthetic, and she basically wakes up with a completed breast reconstruction. And the other kind of abbreviation we like to use for this is one and done. And in my own personal experience, about 50% of patients are truly one and done. They don't need any revision surgery. It's not uncommon after breast reconstruction, whether it's based on a tissue expander or an implant, direct to implant, DTI, single stage, there may be some little touch-ups that may be required. If there's a little asymmetry, if one implant has shifted a little bit, if there's a little bit of visibility of the implant or rippling the contour of the implant, we may have to do another little procedure where we use the patient's own body fat and we do fat grafting. We inject a little bit of fat to kind of thicken the layer of skin that overlies the implant so that the breast looks as natural and pretty and symmetrical as possible.
So as we you don't necessarily, as we think through going through this, right? This isn't something that you just necessarily find yourself wanting to do, right? This isn't something you would just, yeah, I'm going to niche in this. This sounds great. So how did you find yourself evolving into this type of specialty? Because from my understanding, I mean, this really takes some skill.
So, to become a board certified plastic surgeon, there's a lot of training. And my own training included, after medical school, after college and medical school, a total of 8 years of surgical residency training. First in general surgery and then in plastic surgery. And within plastic surgery, there are multiple subspecialties where people can wear a true supra subspecialty niche. For example, there are plastic surgeons that focus almost exclusively on breast reconstruction. There are plastic surgeons who may exclusively focus on facial plastic surgery, or even getting even more focused, something just like rhinoplasty, where their mainstay of specialty expertise would be just nose jobs, rhinoplasty. One of the reasons I went into this specialty is because I love the variety. And the main thing that motivates me to be doing what I do is to know that I can impact very significantly on patients' qualities of life. And the quality of life is really what it's about. You know, we're not generally, as plastic surgeons, in the business of saving lives because that's not what we do. We're not trauma surgeons, we're not cancer surgeons, but we are improving the quality of life. So if a woman faces the diagnosis of breast cancer, we know that number one priority is to be cured of cancer and live a nice, long, healthy life. But the number two priority, which is not too far away from number one, should be feeling good about herself, not feeling disfigured or deformed, having a good, positive self-image and a positive outlook on life. And all of us, honestly, Alan, we all care about the way we look. You know, we live on planet Earth. We don't know what it's like on Mars, but on Earth, we care about the way we look, and we care about the way we interact with each other. And so a positive self-image is going to reflect back on the way we carry ourselves, our confidence, and so on and so forth. So it's about quality of life.
That makes sense, which everybody deserves. And as you walk through this process, and we all expect and hope for an ideal outcome, right? Which essentially is being able to remove the cancer and wake up with the augmentation being complete, or the reconstruction being complete. And I understand, or I've come to understand, that whenever you meet with patients that are considering the surgery, you have to lay out a potential possibility that that's not always going to happen.
True.
Can you kind of break down what could cause some of that to happen, and why that has to be laid out there?
Absolutely. So the key factor in any successful operation, other than performing, of course, a correct and properly executed operation, is blood supply. And the blood supply to the skin and nipple, and let me just say, I didn't mention this earlier, but unless the cancer is very close to the nipple areola, in the vast majority of cases, we can do what is called a nipple-sparing mastectomy. The abbreviation is NSM. And a nipple-sparing mastectomy means that we can take out the breast tissue but preserve the entire skin envelope of the breast. And that almost always ensures a more favorable aesthetic outcome. So back to the blood supply, when the mastectomy is performed, we have to remember that not only the breast tissue is being removed, that includes the cancer, but all of the blood supply and all of the nerves that travel through the breast up to the skin and up to the nipple is also being removed. And therefore, the end blood supply after the mastectomy is completed is coming purely from that skin envelope. And thankfully, in the vast majority of cases, that blood supply is adequate to allow the skin and the healing to take place without incident, without complications, such as ischemia or breakdown or wound healing delay, etc. Our judgment in surgery needs to be based on not only our clinical experience, but also we have technologies now that are available to assess hemoglobin oxygen saturation, which is an indirect reflection of blood flow, and we have other technologies where actually we can perform a kind of a real, in real time, an arteriogram. An arteriogram is kind of like a roadmap of showing which blood vessels are open and what the blood supply actually is in that skin. And so we have these technologies available to us in the operating room, which allow us to depend not only on our clinical judgment and our naked eye, which has been proven to be not always 100% reliable. There's no substitute for clinical experience, and of course I've been doing this for 35 years, and for that there is no substitute. But I will be the first to admit that if I was just relying on my eyes to make a determination, that can be a trap, because the blood supply is on a continuum, and after the breast surgeon completes his or her mastectomy, right now, in this moment in time, the blood supply might be pretty good, but it might not be so good in an hour or two. So that's where the technology helps us predict whether or not it's good enough now to be able to depend on our decision to move forward with an immediate reconstruction. And so that data is critical, and it has proven very, very valuable for us in achieving a very high success rate with, thankfully, a very low complication rate.
It's incredible what experience combined with the technologies available to us today can accomplish. That is remarkable. I want to kind of change subjects a little bit as we go down this journey that patients go through. And one part of that journey is the emotional impacts from somebody being diagnosed with breast cancer and then having to go through the considerations of this and making the decision to, of course, have the removal surgery, but also have the reconstruction surgery. Would you mind kind of talking to the impact of that the emotions of that decision, and how you help guide patients through that process?
Absolutely, absolutely. So let me just take one step back and remind our listeners that there are two basic surgical options when treating breast cancer. And this is, of course, going to be very dependent on the patient, her presentation, if it's very early and it's a very small tumor versus a larger tumor, whether it's a very aggressive tumor or a very low-grade tumor. All of these things are very important considerations for the final determination. And there are all kinds of histologic markings. Histology means the tissue type that is analyzed in the laboratory. So there are markers, etc. But the two basic options are what are called breast conservation surgery, where the only tissue that is removed by the breast surgeon is actually the tumor itself. That's called a lumpectomy. And the other option is a mastectomy, where the entire breast is removed. So the lumpectomy goes along with what's called breast conservation surgery. The mainstay of that is twofold. One, if the patient chooses to opt for conserving her breast and only getting the tumor removed, if the breast surgeon feels that is a good option for her, then the breast by definition will become smaller, and we may have to do some sort of a symmetry operation on the opposite breast to make them even. But more importantly, the lumpectomy always goes hand in hand with the need to perform follow-up radiation therapy. And conceptually, for our listeners, so that we understand why that is, if we've saved the breast, all the breast tissue is there except the tumor that was identified, diagnosed, and removed, we still have that breast tissue that it is at risk for forming a new cancer in the future. So you want to think about the radiation of the breast as kind of a sterilizing procedure to kind of knock out the chances that the remaining breast tissue that we have saved won't get into trouble in the future by developing a new cancer. That risk is different if the mastectomy has been performed, the whole breast has been removed, and the vast majority of patients who have a mastectomy instead of just a lumpectomy will not need radiation. And we can get into that a little bit more, Alan, because there are plus sides and minus sides to getting radiation therapy. But our listeners should know that if they choose to conserve their breast and just have the lump removed, that's okay, as long as they understand that there will be radiation therapy that will follow almost in 100% of cases. Now, back to your concerns about the emotional gravity of this journey for patients. as we started our conversation, this is probably one of the most emotionally impactful diagnoses and surgical journeys that a patient can go through, because it's got that double component of worrying about cancer, which is a scary diagnosis for anyone, and the worry about disfigurement. If you think about having to have your appendix removed, obviously that's not cancer, but usually it's done with a small laparoscopic scar, and you have maybe one or two scars that are about the size of your fingernail, and that's the end of the story. And so that's not going to really be impactful on patients' self-esteem, on their sense of confidence, etc. When you're talking about breast surgery, and most women most human beings have a sense of self-image and confidence. We all worry about different parts of ourselves, but hopefully we are all walking around feeling at least okay about ourselves. And when something happens that requires surgery that could potentially be disfiguring, that could be very impactful for sure. And we talked about the fact that if a woman is impacted by disfiguring breast surgery, this can make her feel very insecure with regard to her partners in life, and that can be distressing, because that can definitely impact negatively on quality of life. And if this particular person doesn't have a partner in life, it may impact her confidence as far as dating, etc., etc.
Absolutely. And we actually recently met with a couple of your patients and had a chance to hear their stories. And I want to take a quick moment to introduce one of them and have their testimonial incorporated in case you're going through this. These are some things that have stood out to patients that have come through Dr. Kalus's office, and they want to share a couple of tips and things to consider as you're going through your journey of this process.
After having 3 children, my body definitely went through some changes. I wanted to be able to go to the beach with my family and play with my children and not feel self-conscious. A friend of mine recommended Dr. Kalus and his work, and so I decided to book a consultation. At my consultation, Dr. Kalus was very professional, extremely knowledgeable, and did a wonderful job answering any questions and concerns I had, and really put me at ease. After my procedure, I have regained so much confidence, and I truly have Dr. Kalus to thank for that.
Yeah, that's great, Alan. And I think the patient testimonials are invaluable, because even though I'm the plastic surgeon and I have a lot of information stored in my head, and I can certainly do my very best to impart that information, there's no substitute for hearing it from the patient who actually went through that journey. I'm going through it with her in terms of guiding her through the process, but I'm not the one having surgery. I'm not the one experiencing the pain. I'm not the one worried about the scars, because they're not on my body, they're on my patient's body. But of course, I do everything I can to sympathize and empathize with my patients on their journey.
And in today's world of Google and Facebook and WebMD and every other source of information that exists, and there are plenty of them, there's likely to be some misconceptions whenever it comes to this. Rather complex procedure, lots of emotional things going on as you're going through this journey. Would you mind kind of maybe sharing a few of those misconceptions that you know of and dispelling them, or explaining why they're not quite accurate?
Sure. Well, let's start by making a general statement. I think a lot of patients, with the information that is available to us today, which is phenomenal, between just standard Google or all of the AI options that we have, ChatGPT, etc., we have to be very, very careful with substituting the input of the physician team with Dr. Google, because Dr. Google provides a lot of information, and I celebrate an informed patient. I always like it when my patients are more informed than not informed. However, there are plenty of opportunities for misunderstanding and misconception, because our listeners are, for the most part, usually not doctors or healthcare professionals. They haven't had all of the training to be able to understand and process all of that information. And the information out there generally tends to be very objective and unemotional. And unemotional information can sometimes be harsh and scary, particularly if one is researching statistics. And sometimes one can get very scary misinformation that can lead you down a rabbit hole that may not even be necessarily relevant for your particular case. So I think it's okay to do self-study and research. I encourage it, but I want that always to be filtered and processed with the understanding that you really want to get the surgeon's input on, hey, I read this and I read that. Is this true? Is that accurate? Is this incorrect? I have many, many patients coming to tell me in the consultation, they're starting with the conclusion. I know that this is so, and I know that that is so, and I immediately have to interject and correct them. Actually, that's not so. You might have read that, you might have heard that somewhere, but that's incorrect. And I think the other thing that I wanted to mention, Alan, that is particularly relevant to breast reconstruction, no surgery can ever be promised without a risk of complications. And unfortunately, breast reconstruction is an area that can potentially be fraught with a lot of complications. And in the space of breast reconstruction, it is particularly devastating because we already touched on the emotional impact of the diagnosis of cancer, the emotional impact of fearing disfigurement, the excitement, empowerment, and encouragement by knowing, oh, I can either save my breast or I can get my breast reconstructed at the same time. That's great news. And then there's a really hard fall if that goes south. If there's a complication and the reconstruction fails, that can be incredibly impactful. And it can result in depression, it can result in anxiety, it can result in relationship challenges. I've seen sad situations where initially the patient's partner may be very supportive, and then eventually through that very difficult and challenging journey, there may be relationships even that break apart because the partner is not able to sustain that level of support. And so everybody needs to be very emotionally strong. I always encourage psychological support through all of this. I encourage all of my breast cancer patients, if they don't happen to be in therapy, to at least consult at least once. I generally recommend a female therapist for obvious reasons, to at least have a conversation that the patient may feel only comfortable with a professional therapist or counselor or psychiatric social worker, to just have a conversation about all the issues and concerns swirling in her mind around the diagnosis that she may or may not feel comfortable talking to her partner, boyfriend, girlfriend about. And someone who can be objective and professional can be invaluable. So I just wanted to throw that out there as part of what we're thinking about.
Absolutely. And when interviewing a handful of your patients, one of the things that really stood out to me in going through their testimonials was how much they felt that you cared about who they were and what they wanted to look like at the end of this. And as they went through different interviews and selections and considerations, they felt very often that they, in other doctors that they were meeting with, that it was very medical, it was very straightforward, there was not necessarily that emotional aspect and connection. And whenever they were meeting with you, they felt very connected, they felt very cared for, and they were looked at in a manner that made them feel much more than just a surgery patient, but a human, right? And a mom or a wife that had a life to live after breast cancer.
Well, Alan, honestly, I think that there are many criticisms that we can make of the current medical model. And the current medical model, as hard as we try to approach it with the considerations that you just mentioned, unfortunately the medical model that we have is disease-based and diagnosis-based. And when you walk around on rounds at the teaching institutions, and I'm not taking a specific criticism at any one institution, but of course I've been there because I was not only a medical student and a resident once upon a time, I was also teaching faculty. So one of the things that we're almost always guilty of in the medical model is, even flippantly, you see this in the medical shows. Oh yeah, room 321, that's the breast cancer. Oh, room 44, yeah, that's the leukemia. Well, it's not the leukemia and it's not the breast cancer. It is the patient with those diagnoses. And I try in my practice to never, ever forget that I'm not doing a breast reconstruction. I am performing a breast reconstruction on this patient with this name, with this family story, with this occupation, with this relationship, with these kids, etc. And so I just try very hard to never forget that every single patient has a unique personality, a unique story. There'll certainly be some overlap with regard to concerns and worries, and most of the anxiety, in my experience, that comes up in any medical situation is the unknown. The question, what are the questions that I haven't answered, or that I need to get answered? And most of the anxiety comes from questions that have not been answered. And so I try to leave every patient and every consultation with my patients with no stone unturned and no question unanswered. And I always encourage them to contact us after they leave the office. If they literally get in the car and say, oops, I forgot to ask, we tell them, don't worry about it. Email us, call us back. We will get back to you. We will answer your questions. Because just the diagnosis and just the journey is anxiety provoking enough. Once you add to that mix all the unanswered questions, and it all just becomes a black hole, and we don't want to be there. We don't want our patients to be there.
Dr. Kalus, as we kind of reflect back, we've obviously highlighted one of your patient's testimonials earlier and talked about the many testimonials you've had, but is there one in particular that stands out that highlights the impact that this type of surgery can have on somebody's life?
Yes, I had, Alan, a recent patient who was very young. She was a young mom, under 40, who was a busy veterinarian. And she presented about 3 years earlier, where I wasn't involved in her care, and she presented with severe aggressive advanced disease. And part of her therapy included not only a mastectomy, but she actually required a wide mastectomy, such that she needed a flap reconstruction with tissue coming from her back to get that wound closed, primarily. And that was not a breast reconstruction. That was just to get no open wound situation and allow her to go through subsequent chemotherapy and radiation therapy. And she thankfully was cured of her disease. She had no evidence of disease, active disease. And flash forward 3 years later, she was facing the options of reconstruction. She was a young, very attractive young mom, and she really wanted to move forward with reconstruction. And she had several consultations, and all of them were identifying the fact that she was very thin, there wasn't a lot of skin there, and they were offering the option that we talked about at the start of placing tissue expanders, and not only one, but two, in two separate sequences. And basically the treatment plan that she was outlined was about 3 different operations over the course of about 12 to 18 months. And I remember vividly that she told me something that intuitively would have been evident to me, but she of course shared that she told the surgeons who were offering this to her that she simply can't do that. She can't carve out that much time from her busy life as a young mom and as a vet. And are there any options for a single stage reconstruction? And she did find me because she knew that I had that expertise. And we most recently did a single stage reconstruction for her that ended up being very, very successful. And she was just so grateful that when we met, I realized that our goal here is not within quotation marks a breast reconstruction, but it was a breast reconstruction for this patient with this lifestyle and with these needs. And her goals were to try to accomplish the obvious goals of a breast reconstruction, but within the context of getting back to her very busy life and not taking too much time off. So thankfully we were able to do this for her, and the entire process from the date of surgery to basically back at work was about 3 weeks for her. And she was just so appreciative, and I was so grateful that we were able to accomplish this for her, and fortunately had no complications, because complication risks are definitely higher in the patient who's had previous radiation. Radiation, we touched on this a little bit earlier, but radiation can impact negatively on successful wound healing without complications.
That's an incredible story. It's amazing that she is living a healthy and vibrant life today after having to go through so much. As we look towards the future with breast reconstruction and plastic surgery overall, what are some of the advancements that you've been seeing? I mean, obviously you've been in the business for 35 years now, right? So you've seen a lot of change in the industry over time. What are some things that you're seeing now that you're most excited about to come over the next couple of years?
Well, I'm probably going to get a little bit technical, but the two most major advances are the idea of, one, being able to go to the final single-stage implant reconstruction, the acronym being DTI, direct to implant, that I've incorporated wholeheartedly in my practice. And the tissue expander balloon tissue two-stage process that we talked about earlier is one that in my practice is probably less than 5% of the time. So I'm very excited to be able to offer that single-stage option for patients. The other one that is a more recent advance is a little bit more interesting, and this is going to get a little technical. The under the breast sits the pectoralis muscle. Everybody knows what the pecs are. And the pec muscle sits right under the breast. Historically, most of the breast reconstruction techniques that involved using a tissue expander or an implant, for reasons we don't need to get into right now, there were specific advantages, we thought, to create a space under the pectoralis muscle to get one more layer of protection over the implant or the expander and provide a nice anatomical teardrop-shaped slope to the breast implant, mimicking the natural and pretty breast. And we've since learned, with the use of the techniques that came along with direct-to-implant reconstruction, we actually have a second layer of a material called acellular dermal matrix. That's a fancy term for human-derived skin that is donated by donors, and the skin has all of the cells removed. Now, why is that important? Because when we reject a kidney, for example, from an improper donor, that rejection by our body is occurring at the cellular level. And if you have any biologic implant that doesn't have any cells in it, it by definition cannot be rejected. And this is what's revolutionized our ability to perform single-stage breast reconstruction without the use of the pectoral muscle at all. We don't disturb the muscle, we don't hurt the muscle, we leave the fully functioning pectoral muscle, and now we place the implant above the muscle, and that most mimics a woman's natural anatomy, because in the natural anatomical state, all of the breast tissue lies above the muscle. And so it's very interesting that that trend began with the cosmetic patient in terms of placing implants under the muscle. And then we gravitated toward going to reconstruction with placement of implants under the muscle. And then there was a trend back to understand that with the use of ADM, acellular dermal matrix, we can revert back to placing the implant above the muscle. And that learning curve has brought us back full circle to the cosmetic patient, where we now try, in my hands certainly, most commonly, I favor the ability to place the implant above the muscle, even for cosmetic augmentation. And Alan, this really brings up the interplay between reconstructive surgery and cosmetic surgery. They're both being performed by the plastic surgeon. And this would be a good chance to tell your listeners, where does the term plastic come from in plastic surgery? And not to get too long-winded about it, but the word plastic comes from the Greek root plastikos, which means to change form or shape. And that's why the material plastic is called plastic, because it's malleable and you can change it and move it around. So plasticity, everybody knows that term. Plasticity means movability and changeability. And so plastic surgery doesn't have anything specific to do with materials like silicone or plastic. It has to do with the fact that we're changing the shape and reforming the body. And so the plastic surgeon, a lot of plastic surgeons do both reconstructive surgery and cosmetic surgery, but they're both impacting on the appearance of the breast or body or face, and therefore they're going to be impacting on the patient's sense of self-confidence and self-esteem.
Wow. It's been a lot of information in this episode, and I hope that your listeners have gained some great understanding from it. I hope that it will certainly help them in their, if they're going through this, certainly want to, express our compassion, and I hope that this will help guide those decisions with a great educated and informed synopsis of what's to come. But if you could speak to that potential listener, what would be the advice that you would give them when considering their options for surgery and reconstruction?
Well, I think probably the most important element is feeling a connection with your doctors, feeling that you're being listened to and that you're heard, that there is a listening ear on the other side, that your concerns are being met, that the office staff is addressing your concerns and needs. Sometimes the cold shoulder can be inadvertent, but it nevertheless ends up being that way. And the patient who's going through enough emotional challenges with the diagnosis and all of the questions that need to get answered, you want to feel confident with your team. I think that it is, in this day and age, with the information that we have available, most doctors have websites. On those websites and through Google, there are going to be reviews. You may find testimonials. I think all of these things are very important. In the area of plastic surgery specifically, other than an engaging personality and a nice smile, you want to make sure that this particular team of doctors and the plastic surgeon are good. They can deliver the goods. They're going to be capable with their experience and skill and knowledge to not only answer your questions, but really deliver a good outcome for you. And so I think not only reviews and testimonials are important, but if there are websites with galleries of before and after examples. And then in our office, we also make available other patients. We always ask patients who have gone through the journey with us if they would be willing to speak with future patients. And we have a network. I call it my breast reconstruction network. It's within our office. We have a list of patients who can very much empathize and identify with the next patient who, God forbid, has this diagnosis, and they are willing and able to share their story and answer questions that I believe only a patient can answer for another patient.
Excellent. Well, and if you are listening and you're considering getting breast reconstruction surgery or any plastic surgery for that matter, definitely look up Dr. Kalus at mountpleasantplasticsurgery.com, or of course a quick Google search. Follow him on social media and on YouTube.
And Alan, let me just interrupt and say one more thing that I think a lot of patients may not know, and this is a really important fact. We talked about immediate breast reconstruction. There are 2 points I want to make. There may be situations that are rare with advanced disease where it's not a good idea to go straight to the reconstruction, and it may have to be staged. In other words, the mastectomy needs to be completed, the treatment needs to be completed. We don't want any delay if the tumor is very aggressive. And there may be a complete second stage months down the road where reconstruction can be contemplated. That's fortunately in this day and age a rare event, but it can still occur in unusual circumstances. But the other really important point that I wanted to make is there are a lot of patients out there who have already gone through this journey. They've had their treatment, they've had their reconstruction. It might have been a year ago and it might have been 15 years ago. The body keeps changing. We're aging, there are weight fluctuations, implants get older, they may shift, etc. So the one take-home message that I want to leave for patients is not only do we perform immediate reconstructions for patients who are newly diagnosed with a new disease, but we also perform a lot of revision surgery. And it is the rare patient who has had this type of surgery, no matter how long ago, it could have been 20 and 30 years ago, she does not need to live forever with an unhappy result. And one of the most common corollaries to that is, of course, if it was a one-sided problem, then her other breast might have gotten a little bigger, it might have sagged over years, and she might have some serious discomfort with getting the bra to fit because the breasts are definitely not the same size or shape, etc. So revision surgery and surgery to achieve symmetry can always be done down the road, regardless of how long ago the original surgery was.
Thank you for joining us on Sculpting the Soul. Remember, beauty is not just about looks. It's about confidence and feeling your best. Until next time, embrace your journey and stay true to yourself.